We recognize that advanced maternal age is an independent risk factor for infertility, common major pregnancy complications, congenital anomalies, especially after the age of 35. Furthermore, time constraints related to training can be arduous for pregnant women working longer hours, standing on their feet under stressful conditions. The American College of Surgeons established a Board of Governors Infertility and Pregnancy Complications Task Force to study gaps in the workplace support for pregnancy, parental leave, and lactation for surgical trainees and practicing surgeons.
And in the field of vascular surgery, one potential deterrent for females entering our field who are considering having children is the requirement to work with radiation for endovascular procedures and to wear heavy lead for long cases. Back in 2012, Angeliki Vujika, Amy Reed, and I published a paper calling for the development of radiation safety program guidelines for pregnant trainees and vascular surgeons. Despite the fact that was published, and the fact that we conducted surveys for trainees and established vascular surgeons, as well as program directors, to determine current practices with respect to pregnancy and radiation exposure guidelines, it would never move forward. So here we are, 12 years later, with this finally coming to fruition. Clearly, there was a need then, and finally, in 2012, we have an APDVS collaboration led by our two guests, and under the guidance of a dear friend and colleague and brilliant leader in our field, Dr. Dawn Coleman. And their important work is accepted in the JVSVI and is called Mitigating Occupational Risks for Pregnant Vascular Surgery Trainees. We're so happy to help them celebrate this through our discussion today.
Remember, this is a live show, so you can please send in your questions or responses or comments. You can do that by the web. Go to pollev.com, enter DeBakey, and respond with your question, or join by text. Text DeBakey to 37607 and text in your message, and we will get that answered for you. So both of y'all are kind of new moms, and so tell us about your personal journey, and like, did you plan it? Did you, was it, I mean, Catherine, of course, you were doing fertility, but so tell us about your struggles and what you were surprised about, what you learned from it. I mean, obviously we learn just different things about motherhood at all different stages, but let us know, like, tell us your story.
Christina, do you want to start?
I'm more than happy to. I think I was really fortunate when I was a medical student. I had a senior resident who had two children, and at that time she had told me, there's no good time to ever have kids, and I really took that to heart. I'd always known that I wanted to be a parent, and I think there was a period in my junior years where I think the common phrase is we were not trying to not get pregnant. And I think we were really fortunate. I found out I was pregnant halfway through my junior year, actually right before I started pediatric surgery. And I was really fortunate to have had a pretty uncomplicated pregnancy, and with kind of the structure of our training, actually had our first kiddo right as I started residency. And I was really fortunate to have had great staff in the operating room, great co-residents who were extremely supportive. I think the physical aspects of being pregnant and operating definitely was a learning curve. But I think personally the hardest part was potentially the psychological burden of kind of like we had discussed previously, operating and doing endovascular cases, knowing that I was pregnant. And I think I was really lucky, again, having really supportive attendings and really supportive staff who were willing to work with me. And I'm really lucky to have a kiddo who's almost a year old, and we were just trying to figure out what we're supposed to do for the first birthday, because that seems like something that is maybe more for the parents than it is for the kid.
It is. They don't remember. We had an open bar party at a restaurant, so you can do whatever you want.
So I actually had a very similar conversation to Christina's, actually with Dr. Coleman. So whenever I was a medical student, I did an away rotation up at University of Michigan, and had a very similar conversation where she told me that if you wait for the optimal time to have a kid as a surgeon, you never will. So don't wait around. Choose a time that's good for you. Everybody else can figure it out. And it just so happened that we struggled with infertility for over 3 years before finally deciding, while I was on research, that it was time to look at alternative options. So we ended up going through IVF while I was on my research year, which was actually great because it's fairly involved and there are a lot of appointments associated, lots of medications and specific timing for things, which can be very difficult, I think, as a trainee. And I was fortunate actually to make it through the first 2 trimesters of my pregnancy before coming back into clinical activity. I will say being pregnant with twins and coming back into Q2 call is pretty brutal. But we made it all the way basically to almost 38 weeks. I was 37 and 5 whenever I basically went in and was like, I'm done. We're going to go ahead and do this now. Mm-hmm. So there was basically no complications for my pregnancy. We all went home day 2 after delivery. And because I had gone through IVF, I had the ability to know ahead of time kind of when I was due, and it wasn't a surprise. So we actually put the schedule together in such a way that I was on a fairly light rotation in the 6 weeks leading up to delivery. So while I was on call every other night, it was very minimal home call requirements. I think I went in once in that 6-week stretch to see somebody after hours and definitely didn't have to operate overnight. So that was nice. And then I was back full clinically active, I think two months postpartum. So.
How are you managing childcare?
So we actually send the twins to daycare. They go to daycare while my husband's working during the day, and then he takes care of them at night and on weekends whenever I'm working.
Christina, who watches?
Yeah, we also have a similar arrangement. I think I'm also fortunate that my husband, who is a general surgery resident, is also on his first research year out of 2 research years. So this is our year of overlap. We did send our kiddo to daycare as early as they would take him, 6 weeks. He had new friends, and we're currently in the process of working with some of our co-residents to figure out a nanny share when I do go back to rotations, hoping that we can start introductions early on. And that way, I think it'd be nice for, the kids to also have kind of a built-in play group and built-in friend group. So that is to be determined, but I'm hopeful that it'll work out.
That's a great idea, a nanny share. Because I never would have thought of that, but especially for trainees, because especially if you have different classmates that have kids too, because hopefully you're never going to be on call at the same time, you know what I mean? So, nannies want a job that's 40 hours or more, right? You're not going to be able to hire anybody that you're like, oh, can you just work a few hours at night, the most terrible hours ever, right? Overnight, can you get here at 5 a.m, but I only need you twice because that's not going to happen. But a nanny share is a brilliant idea, and I just wonder if it could be a citywide thing for all trainees. Forget just surgeon. All trainees, where you have some sort of way you could an app you could, and that way it's nannies that understand the medical field and what call is, and nannies that are willing to work odd hours or longer hours. Anyway, just a thought.
It's definitely something that's come up multiple times. So UC Davis unionized whenever I just started residency, and one of the things that we've been working towards is trying to figure out better resources for childcare. Yeah. Because daycare in California is anywhere from $1,000 to $3,000 a month or more per kid. So For me with twins, we had to scramble to find something that we could even afford. And even now, half of my salary every month goes to childcare. Yeah. So it's definitely a real problem for trainees.
And it's not something you want to go cheap on either, right? Because it's your children that you are entrusting in somebody else's hands. I know for Methodist, we're very lucky in that we have a sort of subsidized daycare. It's through Bright Horizons, but it's an actual like brick and mortar place, and they are open when Methodist is open. So like for like holidays, like right now, if you go to, my daughter goes to private school, and like they're off like all the time for like whatever, like the day after Halloween we get off. I don't know why, because I guess Halloween is a big celebration, but like that's not a holiday for me. Not that like I'm mad at that, but that's just, but this daycare, if the hospital is open and they're not celebrating the holiday, this daycare is not celebrating the holiday. So that is kind of nice. And then they are open early and late for pickup. And it's subsidized, so if like you're a trainee, you get like a cheaper price because you work for Methodist. But I know a lot of people don't have that though.
But I think the trainees, at least at the moment, like my trainees, their shift ends at 6, so it's 6 to 6 and such. It's a little more predictable. But as an attending, what the case runs late, the case runs late. I mean, I remember it's very anxiety provoking knowing your child's in daycare and they're closing at 6 p.m. and I better get there on time, because my kid's going to be the last one picked up and the owners are going to be mad at me. I think a lot of people struggle with that too. So it can be hard.
Well, so the next question, can you give us some background as to what motivated you to explore this topic? I feel like y'all have already kind of answered that, like your own personal like just going through your personal life, but what made you decide, okay, I need to do something. This is, something that I'm going to turn into an academic career?
So I think part of it was going through IVF and realizing how difficult that would be while clinically active. I mean, I have multiple co-residents now that we have fertility benefits who are going through either egg retrieval for freezing or actual IVF, and making that work on a surgery schedule is incredibly difficult. So between that and then just navigating being a pregnant trainee, UC Davis has a large number of female trainees, so frequently they're trying to figure out how to enable coverage for multiple trainees being pregnant and going out on leave at the same time, and creating a system that can support that. And one of the things that we've tried to prioritize in the last couple of years is minimizing overnight call, especially in-house call for trainees that are in their third trimester. And then other things, I think the big thing for me, it was probably hardest to come back from maternity leave, not necessarily being pregnant, just because while you're big and round, everybody can see and everybody remembers exactly, like how miserable you are. They can see that you can't see your ankles and nothing fits and you're just miserable. But whenever you come back from maternity leave and you're not sleeping through the night and you can't remember where your car keys are and you're trying to figure out how to time things in such a way that you're minimizing the number of times that you're stepping out of a case to pump. Like all of those things are just overwhelming, especially like the first couple of weeks that you come back from leave. I know for me, like I came back to Q2 call at our university hospital. I mean, I think I saw my kids once a week on average for those first 2 months back. And it was almost traumatizing. I basically, like, by the time I saw them again on the next rotation, I didn't even know what their habits were anymore. They hardly knew me. And so, I mean, navigating all of that as a trainee is difficult. And so I kind of wanted to create something so that people that are trying to support trainees understand what our needs are and kind of how best to help us.
Yeah, and then there's the mom guilt of you feeling like, oh my God, I haven't seen my kids in a week and I'm a terrible mom. Oh, I'm a terrible trainee. Oh, I'm terrible at everything, and then it's like what I call the fecal cascade of just like feeling bad about all parts, because it's hard to be good at everything all at once.
Christina, what are your thoughts on that?
I definitely echo Kat's points. I think while we at my institution don't necessarily have as many female trainees, we do have quite a number of people, at least specifically in my year with my general surgery co-residents, who all had kids coming in or have started families during training. And so I think because our class was maybe out of the normal than what it has been in the past, there was a lot of conversations about what this would look like in terms of call schedules going forward and responsibilities and how do we navigate getting a fetal radiation badge. And I, again, was really fortunate to have had a really supportive group of attendings and, staff in the OR. And it just made me kind of, like Kat said, want to put this discourse out in the literature in a way that people can reference and think about and hopefully bring about some change. I definitely did come into kind of motherhood in a little bit of a different situation because I'm still on research, but I think to all of Kat's points of it definitely is a different beast. It seems like going into our clinical rotations, being a new mom, and hopefully this is the start of more conversations around creating some support for that as well.
But I think it's interesting that, it took 12 years since I wrote that paper that somebody could actually do what you've done. And I think that has a lot to do with culture. I think the culture has changed tremendously since, I had my daughter in 2007 and my son 2003. And back then, you were always like hiding, like not trying to be visible. Like, yeah, I know I'm really big and pregnant, but don't notice, it's okay. I'm doing everything the guys are doing and I'm double letting, even though I don't know any better and I have no data. I'm just putting double let on and all these crazy things that we did. But I think that a lot of it has to do with the support, the women leaders like Dawn Coleman and other leaders in the field that have gone forward ahead and said, you can do this and we'll stand there by you. And then the American College of Surgeons coming out and informing this task force, I think a lot of this has allowed this to come to fruition. So I congratulate you both on that.
I think, like you said, Dr. Shaw, we definitely stand on all the shoulders of those people who came before us and, including yourself, kind of paving the way so that we can talk about it. And I, like Kat, was really lucky to have had someone who sat me down and kind of told me that there is no good time, and if you want a family, you find what works best and you kind of go for it. So I think we're both really lucky to have had mentorship from people to have allowed us to start our families during training.
Yeah, I think it is definitely evidence of a culture shift, right? So this isn't a conversation that you can have if nobody's receptive to it. If nobody wants to hear about all the things that we could be doing better, then there's no discourse that you're going to have. It's just you're throwing spaghetti at the wall and nothing's sticking. So I think the identifying the problem, which is what you did back in 2012, was just kind of the beginning, and the kind of prioritizing we've put on work-life balance and trainee well-being and faculty well-being has just kind of paved the way for something like this to be a discussion that people are open to having.
I just think we're having a webinar to talk about this, and Linda and I have done over 40 webinars on so many topics that nobody would ever have talked about 10, 15 years ago. And, Alan Lumpson put us up to that. He's like, I want you two to do a show. We're like, are you serious? And it was on radiation safety, actually. And it was our first one. So, and we've been very fortunate to bring people like you and other people, single moms, different trainees, all kinds of different things, people with challenges with complicated pregnancies, infertility problems, single moms, all these things. We've let people, and they've been able to speak and express and I went to Bucharest to speak for the International Society of Endovascular Specialists, and which hosts all of our shows on the website. And I met one of the women that was running the whole meeting, and she says, we've been watching your shows. So they're like, keep doing it. We're in Romania and we're watching your shows. And so, we just are happy to help everybody move forward. Let's push things forward so we can all have better lives, be better surgeons, and be better parents, right? So.
What are y'all's thoughts on also, because there's I talked to you about this, Palma, the economics. She won the Pulitzer Prize, Claudia Golden. She wrote that book. It's economics on gender inequality. I'm blanking on the name right now, but I think it's Career and Family. It's a great read for economic purposes. I mean, it's not like a drama or anything, but, she talks about how our society is based on like how we get paid and how we get reimbursed, salaried is based on long hours. So like the longer hour, the harder you work, the longer hours you do, the more you get paid, right? And so in a family unit, there it can never be 50-50. There's always got to be someone that has to be the less hours, the 60-30 at the job in order to do everything for, or pick up at school, do all that. And so what are your thoughts on, equality, like in terms of men, like parental leave for men? Because I think that also, it's like they don't really have that time with the baby either, but like that's important to them, but it would also equalize everything, right? Like a lot of times we talk about mid-career, when we have children in mid-career, and we get behind, right? Because like we're out of maternity leave for however long. I came back, I lost a lot of my referrals. I basically started over again. Or you say no to committee commitments or talking at this meeting because you feel like, okay, well, I got a baby at home, I got to do this. But your male colleagues are saying yes to everything, right? And so now they're ahead of the game and you're kind of left behind because, of the whole family complexity and who's going to do what. What are your thoughts on that?
So I think for my family, things are a little bit non-traditional. So my husband basically, as far as he was concerned, has accomplished everything he wanted to in his career. All he wants at this point is to be a dad. So as soon as I finish training, his plan is to basically retire and stay at home with the kids. So I'm kind of in a unique situation where other than pregnancy and maternity leave, like he's happy to take on that responsibility and that role. And it's something that's very fulfilling for him. That being said, I was fortunate to have lots of support whenever I was out on leave. So like I had multiple abstracts that were accepted for presentation at Western last year, but unfortunately was nearly 35 weeks pregnant with twins. So they were like, we really wouldn't recommend that you fly. So rather than pulling my presentations, they actually left them under my name and allowed my co-residents and faculty to present on my behalf. But I think it's just kind of, it goes to show that you can support women in the same way that you support men. It just looks a little bit different sometimes. And as far as paternity leave, I mean, my co-chief also just became a parent this year. He's got a 3.5-month-old baby girl at home. And so whenever I first started, they only got 2 weeks of paternity leave, whereas he got 6 weeks. So he really valued that time with his family. And I mean, his wife is actually one of our general surgery chief residents. So kind of is in the same boat that we are, where she's working very hard and, she wanted that time with her family as well. So I think it's something that was not necessarily valued before, but I think we underestimate how much our male colleagues really do value that time just as much as we do.
Right. Well, that's great to hear that now, like the men are getting more time for parental leave, because before it was really just 2 weeks. I mean, I think here it's still 2 weeks. Palma, do you know?
No, it's 6 weeks, but for the trainees per ACGME. But the problem is
for males too, like.
Yeah, they do. But the issue becomes, for example, if you have a fellow who used up all their vacation time and then wants to take their 6 weeks, they're allowed to be 2 weeks shy per ACGME. So what about the other 4 weeks? So they'd have to theoretically do those other 4 weeks running into the next year.
Yeah.
And, each program, I think, has to decide what they really have. I mean, do you have enough cases to go around? Because I personally was in that position a couple years ago with a male graduating fellow. And I said to him, I appreciate the fact you can take your 2 weeks, you take them whenever you want, but I can't let you run into the next person's time because they need cases too. And he only got the 2 weeks because I couldn't, and I'm allowed to actually do that because I can't encroach upon my new other trainees' time. But it is 6 weeks per the ACGME. That's been out for a little while.
But I guess
I think it has to be a conversation too, though. I mean, if you're going to take additional leave, I mean, my program director basically offered me as much leave as I wanted. I ended up only taking 8 weeks and using up some vacation as part of my maternity leave. But I think if you're going to take, extended leave and it's going to impact your co-trainees, it has to be a conversation that you have with your program so that you try and minimize the impact to everybody that's going to have to support you.
Yeah, I think that conversation point is really critical, is having those open discussions with the other people in your group. I think for us, I'm pretty close with the general surgery residents in my year since there's only one vascular surgery resident per year currently. And we had, I think, a lot of really good discussions about what that would look like if, one or multiple of us ended up having to go out on paternity or maternity leave. I will say I may need to ask you for the contact of your co-chief, Kat, because I may end up in a similar situation. My husband is a general surgery resident as well, and I so appreciated the amount of time that he was able to take for paternity leave, even if it was maybe shorter than what I would have liked. And I do think that there are ways to support both moms and dads, and kind of like you said, Kat, it just may look a little bit different and may require some thinking beyond what is traditionally done, but it is definitely possible.
Palmer, do you want to ask the next question?
Well, now these guidelines that you've put out, are these recommendations that you've now published, how do you suggest that they get implemented across the country with the different types of programs that there are? I mean, do you think there's going to be some hurdles in implementing that? Just like we just discussed, I think a big program with tons of volume and numerous sites may be able to absorb letting somebody take off the full 6 weeks versus a small program that's a brand new training program just may not be able to absorb that. So I think not everybody, it's not one size fits all, really. So any thoughts on how that can work?
You want to start, Christina?
Sure. I think that's definitely a really good point. Every program looks different. The trainee complement looks different. The structure looks different. The support systems in place all look different. I think in the process of building out these guidelines, we definitely tried to take into account these different situations and offer flexibility in interpreting some of these suggestions. But I do think that the strength of all of this is really to encourage discourse around this topic. And we had a really great writing group, and I know that every individual in that group would be happy to answer any questions if there are trainees or program directors who may have any questions. I know I definitely am. And I think the discussion point is the ability to discuss with other people is, again, the strongest factor, I think, in bringing about this sort of cultural change. But I do think we tried really hard within the suggestions, and specifically in that kind of table towards the end of the manuscript, to allow for some flexibility and some suggestions on how these guidelines can be adapted to different programs.
So I think I agree with a lot of what Christina said, and I think the guidelines just are there as kind of a framework. They're not like a one-size-fits-all, as she said. I think a lot of how we support trainees is going to require a little bit of creativity on our part. So like I know something that UC Davis did that kind of really made a difference for the fact that we have multiple women who are, newly postpartum and coming back to work and pumping simultaneously, is rather than trying to make use of a single lactation room that's across the hospital and away from the ORs, we have, 20 call rooms, like right down an elevator right away from the ORs. They just put a mini fridge in every single room. So now every room can be a lactation room, and it didn't require any major outfitting. I mean, a mini fridge is relatively inexpensive. The ENT department at UC Davis, I think, actually purchased a portable wearable pump that they could, have different residents use kind of during their time postpartum if they were pumping. It's just kind of figuring out how you can maneuver. So for me, it wasn't necessarily that I didn't take call. It was just that I was shifted to a different rotation to try to minimize the work burden for me while I was pregnant. And it's just trying to figure out what resources you have available to you that you can use to support your trainees. And a lot of it's also just open conversation, right? So I knew whenever I was going to be on leave. So I basically talked to my program director ahead of time and was like, hey, this is coming. How do we make this work? How do we minimize the impact? And then the other thing that UC Davis has done, and I think has been relatively successful, is we actually had 4 general surgery female chiefs go out within like a few months of each other, all at the same time last year. The way they tried to absorb that as far as the call pool and covering that much maternity leave at the same time is making use of box call. So our research residents cover a set amount of time on call. And so if they have to get called in to cover shifts, that's how they justify their salary for research. So just kind of making use of resources that exist to try and help minimize the impact so that it's not necessarily seen as a burden, but just kind of something that is a standard part of what we do now.
So one of these recommendations you've made is related to the lead, properly fitted lead, or even pregnancy lead. So I could only imagine carrying twins. That must have been a fun endeavor. It's a lot of lead.
So I think that's one area where Davis actually really struggles. We're one of the few programs in the country that doesn't actually buy lead for its residents. At this point, there is an education fund that you can get every year, and you can choose to use that for lead. But whenever I was initially considering buying lead, it wasn't something that existed. So I ultimately bought my own lead, but most of our trainees actually just use the lead that's available in the hospital. So as far as having fitted lead, that's not a guarantee. And so that's something that I think we really do struggle with. As far as having my fitted lead, what fit me before I was pregnant was definitely not the same once I was 9 months pregnant with twins. So I did actually have to use a separate shield underneath my lead because it no longer closed over my belly. But I think that's probably one of the few areas where having there be something of a, either a mandate or a recommendation from ACGME could be really helpful. Because I know whenever we've discussed it in our program, it's pushback from administration, not from the program. The program doesn't have the funds to, unfortunately, support us in buying our personal lead, and administration doesn't see the benefit in doing so. So having it be something that's pushed from above potentially gives program directors the support that they need to go to administration and be like, hey, look, this is something we should be doing. Here's, the recommendations. We should be in compliance with those. So I think that's something that we could potentially do to help programs that are potentially struggling with that type of support.
So a publication endorsed by the APDBS is certainly, I think, a move in the right direction. What about your fetal badges? Any concerns or any radiation detected on the fetal badge during your pregnancies? Not
a lick.
Yeah. We did another paper on that as well. Wei Zhao and I and Vinita Chandra, we looked at the pregnancy lead. I'm sure you probably reviewed that article in the paper.
But, it is included in the references.
Yeah, but here I am running around with double lead. I was like, I had suspenders, and then I had like a skirt, and then I had my vest, and then I was like putting like a single layer of lead, and I'm like super pregnant, and I'm doing like with cardiac, they're doing a sternotomy, and I'm antegrade deploying stent grafts, and the reps are like, is she gonna fall over? I was like, it was, that was, and I lived in my support stockings, 30, 40s, 100% of the time.
I had Kangol for 6 straight months.
Yeah.
Linda did, right, Linda?
Oh my God, everybody kept saying you have preeclampsia. I'm like, I don't have preeclampsia, I promise. So, in terms of your guidelines for breastfeeding, and let me just review for the audience. One guideline was to make sure that trainees have clean, private, conveniently located lactation rooms with refrigerated storage options. That's a current ACGME requirement. 2, support use of wearable breast pumps that are portable that you can wear in the OR. 3, attending should excuse trainees from clinical duties for lactation purposes at a minimum of every 4 hours. That includes to scrub out in long cases, and that attending should coordinate designation lactation periods if it's going to be a longer than 4-hour case. So the portable breast pumps. My understanding was that now, because when I had Ella, you got, with your insurance, you got a breast pump, but it wasn't portable. But I hear now they're including that. Is that correct?
They are.
Okay, so that's good to know. So that should not even be an issue, like in terms of administration having to pay for it or anything. That should be covered by your insurance.
So, yes and no. So, typically what is recommended is that if you're going to pump, a portable pump shouldn't be your primary pump because they tend not to be as effective as like a plug-in wall pump. Mm-hmm. That being said, some of them are better than others. I fortunately was gifted a plug-in wall pump, so I didn't have to use my insurance for that, and have since passed those along to other co-residents that are kind of going through the same thing after the fact. And I used my insurance to cover the cost of a portable pump. There are multiple types of portable pumps, and not all of them are covered, and some of them are only partially covered. The problem with most of the portable pumps is they're very expensive. So even with insurance coverage, you're still looking at probably anywhere from $200 to $400 out of pocket on top of insurance. So something else to consider. That's actually one of the reasons that the ENT service kind of supplemented the cost for their trainees. At this point, we now have a bunch floating around just because we have so many female trainees. And like, I have 2 female co-residents. One has my wall pump. One has another portable pump that didn't work for me. Mm-hmm. So you kind of create like a little community stockpile of resources over time, I think, too.
And that's probably how it would that's likely going to be the route of like just end up sharing or having a collection in certain departments, because I'll tell you, administration probably won't pay for that because they'll say, well, if we provide you with a pump, we would have to provide everybody with a pump. That's, so. But that is that I wanted to point that out because that has changed from like 4 years ago. At least now before it was like, no, you got the Spectra and that was it, which didn't really do much of anything. So, and I actually, it's so sad. I pumped 3 days into coming back to work and I quit. I was like, I can't do this. Cause like as an attending, like the 3rd day I was stuck in an 8-hour case and it was an emergency and I couldn't leave. And, I just was like, I can't, I didn't pump that much anyway. And I'm like, this is not working out for me. But my little sob story. Palma, what was your experience?
I was a single mom, so that was not even a consideration. I was survival for years.
Did you pump or did you?
No, I couldn't. I was like,
not happening.
Like feeding my child Ensure, like, Paolo, just take this Ensure. It'll be fine,
Well, they turned out with good-looking kids that are healthy.
Yeah, the kids are good. I know. I don't know how this. Water them and then they grow. It's just really straightforward. No, I had, that's the child care thing is a big deal. When I went to Boston, I had no family. And then I met this lady that ran this like Hispanic daycare. And she used to make my son's food from scratch. She'd blend it and all this. I was like, oh my God. And she was like a second mother to him. And then when I didn't have her, then I found a family. It took like an entire family to watch my 2 kids. And you just find a way. But I think everybody has a different way. There's not like, there's not one way that it's going to work for everybody. It's so different depending upon your situations are different. So I think that's very anxiety provoking. And when I was coming, my kids are 2003 and 2007. I mean, I had no one to talk to. I was like, oh, you're double letting? Okay, I'll do that too. I mean, and it was very stressful. So I think you're in a better place. And I'd love to know what you think it's going to be like for the trainee in 10 years. Do you have a vision of what it's going to be like for someone like you in 10 years? Can you look into the future?
I think there's definitely some conversations around, like we had discussed previously, leave policies and also kind of national benchmarks for resources like lead and access to fetal radiation badges. I think all of those things are hopefully going to become the norm as opposed to the minority. I also think this paper definitely focused on pregnancy, but kind of like Kat mentioned previously as well, the experience of going back into training after having kids also requires a lot of support, and that is not just support for pumping, which I know has definitely been better in the past 10 years, but also support for childcare and, getting your child to the childcare. And I think if those conversations can happen more and more frequently, then hopefully more places can have resources like we previously described, childcare that is open on the days that the hospital is open, which is most days of the year, and, hours that are more flexible and childcare benefits. And I think really establishing benchmarks and guidelines for, the journey for trainees who have kids and are just starting families. I think that is hopefully going to be the next set of guidelines that we can focus on.
I think for me, my hope is that over the next decade, it's going to be kind of the same thing that we've watched with conversations about burnout. Now it's not just something that, you hear every once in a while. It's kind of at the forefront of a lot of what we're doing within the Society for Vascular Surgery, focusing on how we retain a workforce that wants to do what we're doing, right? So, I mean, whenever I first came back to work, I, was pumping regularly, like all over the place, in the operating room, in the resident workroom. And I can remember being at Kaiser, and it's two older private practice guys that have been there for, 10 years. And they don't have any female faculty that actually work there with them in vascular. It's just those two guys. And one of them came to talk to me about a patient, and I was pumping, and he's kind of looking around, and he's like, construction's really loud over here. I'm like, construction, huh? And he's like, it didn't click for a second. Then all of a sudden he's like, oh. And like, this is a 6'3", 6'4", 350-pound man, and just ran away faster than I've ever seen him move. And 5 years of working with him. And it was kind of it caught him so off guard, I think, to have a trainee that like this is not something we see normally. I think my hope is that in 10 years, being a parent, being a surgeon and a mom is not necessarily something that's abnormal. It's something that's it's what we do. It's what we support. It's who we are. As we have a more female workforce, why shouldn't we expect to see things that are associated with being female and being a mom? You want to retain a diverse workforce, you have to be able to support it. So I think that's, in the next 10 years, what I want to see is that it's not only a few programs that are equipped to support female trainees. It's most programs are equipped to do that. And it's what we do.
And I think we're going to be giving some closing comments. I wanted to know, have each of them give some advice to the people coming behind them, maybe something you want to convey to them, a message, an inspirational thought, or something like that.
Well, what Catherine said, it's funny, he was caught off guard, but he needed to see that, right? Because, the more, he probably never even thought about, you don't know what you don't know. So you said they've never had female faculty. They were, the female, like, residents are kind of like their only exposure. And so he probably didn't even realize that was even an option, like portable pumps, you know what I mean? And so I think as long as they're open to change and they realize, like, now he knows, right? So now, he might be more aware the next time he has a female trainee that might have just had a baby, that, okay, maybe they're, maybe I, like, not look so frightened when I'm talking to them, to not make them feel awkward, to normalize the fact that this is a natural part of being a mom, and like just continue the conversation. The more we normalize it, the more it'll be, standard, like everybody's okay with it. It's not this, difficult topic to talk about, or a weakness or something to judge, or, that kind of thing.
I will say he was far less disturbed the next time I was on service, and we actually had 3 female chiefs at the same time, all pumping at the same time. So it was like a symphony of breast pumps if you go into the resident workroom. And luckily by that point they were like, all right, this just is what it is. See you on the operating.
Right.
And I think it's possible. I think we're sometimes really scared to approach topics that we think are going to be received negatively. I can remember being on the interview trail and thinking that I don't want people to know that I'm married necessarily, because I don't want them to ask whether or not I'm considering a family. Like, I was sometimes scared to wear my wedding rings whenever I was interviewing, depending on the program. And to think that we're at a place where the entire society is considering these guidelines as something that, we want to adopt, as something that we want to try and do to make things better for trainees, for female faculty. It's possible. It can change. It can be better.
Christina?
And I think maybe the only other thing I would add for, the trainees that are coming in after us is the same thing that I think Dr. Coleman told you, Kat, and my senior resident told me. There's never a good time. And, if you have any questions or any concerns, I think any of us, and I guess I don't want to speak for other people, but we would be more than happy to answer questions or, reach out. We are here to talk about these issues. And like Kat said, we can make this work.
I think it can be stressful, and I think all I knew was I was not going to not have kids. I was like, that's not happening. So as terrified as I was, to, oh my God, get pregnant and have people find out and this and that, and am I going to, and everything you think about, like, am I going to actually be able to do this and be successful? You have no idea, right? You're like clueless. And but I just knew that not having kids was just not a consideration. Like, that's just not happening. And then everything else was just like, oh, well, I guess you got to go with it, just make it work. So.
Well, you have to get through it, right? I mean, there's no giving them back. So
they're worth it.
They're worth it. So
they're worth it. They're worth if you have stretch marks or every extra pound or everything, those kids are, for me, that was a must. I was going to be a surgeon, but I was going to have my kids and was going to somehow make it work. So
very true.
I will say I have been happier as a trainee, working harder in the last year, because whenever I get home, I'm not just free. I can't just relax. I come home to twins, right?
Yeah.
I have been happier and slept less and worked harder in the last year as a trainee than I ever have before. And I feel far less burned out than I did 2 years ago. So I think you find what you want in life and you make it work.
Yeah. Well, thank you so much for being on our webcast and taking time out of y'all's schedules and being moms and all the hard stuff that comes with everything with our job. And I look forward to your future work and committee work and what you're going to do for us and the society.
And I'm just really proud of you both. And I know you, and I'm very appreciative that you've come on the show. And I really look forward to working with you going forward as well. Thank you.
Thank you for having us.
It was a pleasure.
Have a good night.